Welcome to Rheumatology. So today we're going to cover everything that we probably need to know when it comes to boards with regards to rheumatoid arthritis, gout, pseudogout, scleroderma, and seronegatives. Okay. So we're going to cover pretty much most of the high yield content that you actually need to know for the boards. So let's start with rheumatoid arthritis. So when it comes to rheumatoid arthritis, number one, your body is going to be predisposed due to a certain reason to getting rheumatoid arthritis. So what is the HLA type that actually predisposes you to it? D. So what you really need to know is HLA-D specifically. Just you don't have to go more specific than that for the boards. I think HLA-D is what you need to know. So once you have this HLA-D, genetically you are predisposed to getting rheumatoid arthritis, but you need something from the environment to trigger production of antibodies. So what are some of the triggers that we know of? Smoking. Now smoking is a big trigger. Why does smoking increase the risk of rheumatoid arthritis? So they've actually identified an enzyme, which is pretty cool. They've identified an enzyme known as PADI. It's phosphatidyl arginine deaminase. The role of this enzyme is actually convert arginine, which is an amino acid, to citrulline. Now your body should normally not have citrulinated peptides. So the moment you convert the arginine to citrulline, this makes this citrulline a foreign product and therefore becomes immunogenic. And now you're going to produce antibodies against this citrulinated peptide, and hence the term anti-CCP. That's how the CCP actually comes into existence, right? So smoking is a big risk factor for development of rheumatoid arthritis. What else is another important risk factor? Gingivitis. Yes, so people who actually get gingivitis are actually prone for it. Why? What if a bacteria was cool enough to actually carry the PADI enzyme with it? Yes, so we have a bacteria which is called Porphyromonas gingivalis. Porphyromonas gingivalis causes gingivitis, but it carries its own PADI enzyme, and as a result it's going to convert the arginine to citrulline and start the whole process. So smoking and infection in the gums are two big existent risk factors you can consider it. So now let's go into rheumatoid arthritis itself. So when it comes to rheumatoid arthritis, you need to know what happens. Obviously the joints are going to get affected, right? What is the most common joint to get affected?
Small joints. Small
joints, but classically the first one is MCP. Metacarpophalangeal joint is what's going to get affected, followed by PIP, proximal interphalangeal joint, never distal interphalangeal joint. That's the most important thing. But can rheumatoid arthritis affect pretty much any joint in your body? It can. And is this normally symmetrical?
Yes.
It is symmetrical, right? It's symmetrical. Is it inflammatory?
Yes.
It is inflammatory, okay? So small joints will be affected. It's symmetrical, and a very classic feature that most of these patients, not just rheumatoid arthritis, but pretty much all of rheumatology, when your joint is involved, you will have early morning stiffness for more than 1 hour. More than 1 hour you will have early morning stiffness. As the day progresses, it will get better. So that's a very important key feature, not just for RA, but pretty much across the board. Okay, so joint involvement wise, apart from saying MCP PIP is affected, you can affect your thumb joints, you can affect your wrists, right? You can also affect your cervical spine. Now some of the classic features which we don't see much anymore for rheumatoid arthritis, because we treat them well now compared to before, but what are some of the important features when they have had erosive rheumatoid arthritis? You'll have something called a swan neck deformity, boutonniere deformity, Z-shaped thumb you'll have. You can also have ulnar deviation, radial deviation. Those are some of the features that you can expect to see in your patient's hands. What about in the neck? Can something happen in the neck in these patients?
Subluxation.
Subluxation of what? Which joint?
C1,
C2, which is known as atlantoaxial subluxation. So the board question is also going to give you somebody with suspected RA is coming for an elective surgical procedure. So they're going to ask you, what are you going to do in this patient before you actually do the surgical intervention? So what would you do?
X-ray.
You want to do an X-ray. What type of X-ray? Flexion extension X-ray, and it has to be lateral view. So that's important, right? Flexion extension X-ray, lateral view. And if you actually see that this patient actually has atlantoaxial subluxation, now that is concerning. So if you are still going to do a surgical procedure because you need to, what would you do when it comes to intubation?
Fiber optic.
you actually do something called a subglottic intubation. Okay, and the subglottic intubation is going to prevent any damage to this. Now, what is the concern? Okay, if you have an atlantoaxial subluxation, is there a problem? If something prolapses over there, it's terrible, right? What would happen to your patient? You'll become quadriplegic, right? Because you're literally going to hit right here at C1, C2 level, completely you're going to be quadriplegic. Now, that's the most common answer, but what else can also happen? Remember, your blood supply for your posterior brainstem actually comes from vertebral arteries that's going to combine to form your basilar artery. Your vertebral arteries actually runs in that region. So if you compress your vertebral arteries, you can actually have posterior brainstem strokes. So they can always give you ataxia as an important feature in these patients. Okay, so from atlantoaxial subluxation, you need to know about that as well. Start from head and work our way down and cause whatever other problems can happen with rheumatoid arthritis. So what happens here in the throat of a patient with rheumatoid arthritis? Right, so you can have cricoarytenoid cartilage dysfunction, and as a result you will have hoarseness and also can cause some dysphagia, and you can have problem with intubation even in those patients. So that's another thing to be mindful about. So now let's start with the eyes. Does rheumatoid arthritis cause any problem with the eyes? Yes, what does it do? More than uveitis here, it actually is going to cause keratoconjunctivitis. Okay, which is keratoconjunctivitis, SICA is what we think about, which is dry eyes. Now, is there a specific syndrome that you got to think about when it comes to rheumatoid arthritis and dry eyes?
Sjögren.
You will think of Sjögren syndrome, right? When you think of Sjögren syndrome, it happens because you have autoantibodies being produced against your lacrimal glands as well as your salivary glands. So they'll classically present saying, hey, you know, my vision feels funny, I feel like I have sand in my eyes. Those are going to be complaints, and they don't have much tear production. And in the mouth, they'll say they don't produce much saliva, so they're going to feel very dry, and they can have development of a lot of dental caries. Now, how do you diagnose Sjögren syndrome? Is there a clinical test you could do when you're suspecting Sjögren syndrome? Yes, so but if you want to diagnose them, what you really want to do is a blood test, right? You can do Rho and La, which is SSA and SSB. And that will be diagnostic. If you have SSA, SSB positive, you got your diagnosis. But as a clinical test, can you do something to see if there's enough tear production? It's a litmus paper. It's called a Schirmer's test. Okay, when you're doing a Schirmer's test, you're putting a litmus paper below the eye, and what you're looking for is how much does it get wet, right? How much tears are produced. A normal test is you need to produce at least 15 millimeters within a 5-minute period. If you produce less than 5 millimeters in 5 minutes, that means you're not producing enough. So that's a good sign. But for diagnosis, that's not good enough. You need to diagnose it with antibodies. So Rho and La is what you want. SSA, SSB. What does SS stand for? Sjögren syndrome. And SSB is Sjögren syndrome B, right? Say you have a high suspicion and you get the Rho and La and it comes back negative. What's your next step? Yes, what you do is a lower lip biopsy, and what you're going to show is destruction of very small salivary glands, and that's going to be diagnostic. So they will ask you this question. It looks and sounds like Sjögren syndrome, right? But your SSA and SSB is negative. What's the next step? Look for that lip biopsy. Okay? I mean, you can biopsy anything that typically it's the lip, but you're looking for destruction of small salivary glands. Okay. Now, what is the problem of having Sjögren syndrome? I mean, these problems, fine, you get dental caries and a little bit of visual disturbance. Not a big deal, right? What are you worried about when it comes to Sjögren syndrome? Lymphomas. So what are the 2 types of lymphomas you should think about in these patients?
Non-Hodgkin's.
Non-Hodgkin's B-cell lymphoma, and number 2 is Maltoma. What else should you worry about in somebody with Sjögren syndrome, especially if it was a female? Rheumatology hates females, men, they kind of like. The SSA and SSB, can it cross the placenta?
I guess yes.
Yes, it can cross the placenta and actually can cause heart blocks in baby. So that's something very important to think about. Now, Sjögren syndrome is not something that always has to happen only with rheumatoid arthritis. It can happen by itself. It can also happen with lupus. Okay. Now, those are the important things, points wise, you have to remember. Now, when it comes to treatment of Sjögren syndrome, right, how do you treat them? What about the eyes? What do you do for the eyes? Artificial tears. Pretty straightforward, right? What about the mouth?
Sugar-free
Sugar-free candies, right? It's basically gustatory stimulation, and the fact that you're chewing, and it kind of makes you produce more saliva. Fine. But if you had to use a drug to treat them, what would you give? Civamelin or pilocarpine. Now, important thing, before you pick that answer, you would absolutely make sure your patient does not have what? Huh? Glaucoma, not open angle closure glaucoma. Okay, and acute angle closure glaucoma is an emergency for ophthalmology. So you have to make sure the patient does not have that. Okay, so that's Sjögren syndrome as an association with rheumatoid arthritis. Okay, let's work our way down. Let's go to the lungs. When you have rheumatoid arthritis, what can happen to your lungs? You can develop interstitial lung disease. Yes. What else can happen? You can have multiple different things that happen to the lungs. You can actually have a cryptogenic organizing pneumonia. You can have bronchiolitis obliterans. But one important syndrome that's associated with rheumatoid arthritis affecting the lungs is called Kaplan syndrome. Kaplan syndrome with a C. Now, when you have Kaplan syndrome, what you actually have is nodules in your lungs. And apart from that, you'll also have interstitial lung disease and pneumoconiosis. But you don't just randomly get pneumoconiosis. Pneumoconiosis typically happens classically when you're exposed to coal, like coal workers' pneumoconiosis, or people who are mining sand, you get silicosis, right? Or somebody who works with asbestosis. So you will have to have exposure to some substance to actually cause it. But if you saw interstitial lung disease with nodules in the lungs and rheumatoid arthritis with exposure, then you think of Kaplan syndrome. Now, important thing about the nodules is going to be in your bases, not anywhere else. Basilar nodules is what you're going to look for. So that's going to be Kaplan syndrome. Now, let's move on to the abdomen. Just to finish up the syndromes first. What other syndrome would you have with rheumatoid arthritis? Felty syndrome. What is Felty syndrome? Not abdominal pain. You'll have rheumatoid arthritis, but what would happen in your abdomen? Something would become really big. Splenomegaly. So you'll have splenomegaly and you'll also have neutropenia. Now you can have pancytopenia, but your classic feature is going to be neutropenia. Okay. When you say neutropenia, what should your absolute neutrophil count be?
Less than 1.5.
Less than 1500. Absolute neutrophil count is defined as neutropenia. Now, if it is mild, used between 1000 to 1500. Moderate is 500 to 1000. Less than 500 is severe. If somebody's got neutropenia by itself, it is a problem, but you don't do much until the patient actually develops a fever. If the patient develops a fever, now you're worried about neutropenic fever. When somebody's got neutropenic fever, what is the number one organism you should always worry about? Pseudomonas. When should you consider adding MRSA coverage? Previous cultures positive for MRSA, good. There's about 5 indications.
Recent IBM antibiotic.
This is just for the RA, right?
This is for neutropenic fever. Just to make a quick pit stop there, since we're there, just to integrate it. Hypotension, if somebody's hypotensive. If somebody's got a port infection or some form of line infection, then you'll do it. If somebody's got a skin infection, such as cellulitis, or if you have a pneumonia in the lungs, then you will cover for MRSA. So that's something again to be mindful about. So Felty syndrome happens with rheumatoid arthritis. Fine. So now let's go to the lungs back one more time. When you go to the lungs, we spoke about Kaplan syndrome, but again, you can have pretty much a lot of other problems that can happen with your lungs too. Could you develop a pleural effusion in your lungs with rheumatoid arthritis? You can. What type would it be? Would it be exudative or transudative? When you say transudative, it's typically only 3 things. What are the 3 things that give you transudative? The failures: heart failure, liver failure, kidney failure. Those are the 3 that gives you transudative. The moment it is exudative, you think of infection, inflammation, malignancy, right? So here, it's going to be because of an inflammatory cause such as rheumatoid arthritis, right? So the pleural effusion can be actually pretty big. But something very unique about rheumatoid arthritis pleural effusion is what? Yeah?
pH less than 7.3.
Yes, so pH should be less than 7.2. Okay? When you're thinking of a pleural effusion, one of the very key markers to indicate an infection, because exudate could mean infection, inflammation, or cancer. It doesn't imply infection, right? But what defines an infection is the presence of a pH less than 7.2, and number 2 is glucose less than 30. less than 30. So pH less than 7.2, glucose less than 30 is indicative of infection. Cool enough, in rheumatoid arthritis, pleural effusion, it will also be the same. So pH will be less than 7.2 and your glucose will be less than 30. But the key differentiation factor here would be presence of lymphocytes, not neutrophils, because this is not an infection. It's more of a lymphocyte process, so you'll be lymphocyte predominant, and that's how you'll be able to diagnose it. And obviously, a Gram-Stinin culture won't be positive here. So pleural effusion with rheumatoid arthritis is something very important to remember. Okay, let's go to the heart. Can anything happen with the heart? What's the number one cause of death in patients with rheumatoid arthritis? Huh?
ASCVD.
ASCVD. So what happens is when you have rheumatoid arthritis, you're in a very high inflammatory state. Increased inflammation actually elevates atherosclerosis. So increases your ASCVD risk, and MI is the reason the patient is actually going to die. So don't pick anything else, no pericarditis, no valvular pathology, no dissection, no. It's MI is your most important thing to remember here. Okay, so that's going to be for your heart. Now, what else can happen what is the most common extra-articular manifestation of rheumatoid arthritis? Because there's a lot, right? But what is the most common extra-articular manifestation of rheumatoid arthritis? Subcutaneous nodules. Okay, the subcutaneous nodules are the most common extra-articular manifestation. So you'll actually find it in the extensor surface of your arms, close to the olecranon process here. So it can sometimes be thought about as a gouty tophi. So don't get confused, but it's just subcutaneous nodules that happen with RA. The same way the rheumatoid nodules form is the same nodules that's forming in the lung too with Kaplan syndrome. Okay. So what else can happen in your joints, in your patients with rheumatoid arthritis? Anything else? Due to not a joint pathology, but instead because it affects your blood vessels, you can actually develop wrist drop, and you can develop foot drop. Why does wrist drop happen?
It's the laxity between this from the joint.
One of the big nerves that actually causes your wrist extension, if that gets affected, you'll get wrist drop. Radial nerve. So you can actually have radial nerve involvement and therefore develop a wrist drop, or you can get foot drop. Foot drop is because of which nerve? Common peroneal nerve. And why does this happen? Because of vasculitis. Whenever you have a vasculitis affecting a blood vessel that actually supplies a large nerve that actually has got a fancy name like these, you call it mononeuritis multiplexa. So you'll actually have mononeuritis multiplexa that affects radial, common peroneal, foot drop, and wrist drop will happen with RA. Okay. Now, what else could happen with rheumatoid arthritis? You can have serositis, pleurisy, but again, more so with lupus. Here, not so much. These are your major ones. Something else for you to be mindful, if somebody comes with rheumatoid arthritis and has swelling around their calf, okay, you'll have to think about, okay, could it be DVT? But there's something that happens behind your knee. It's called a Baker's cyst. When the synovium hypertrophies a lot, you can actually form a Baker's cyst which can rupture, it can get infected and whatnot. So always think about a Baker's cyst getting ruptured. Whenever you have a patient with rheumatoid arthritis that's presenting like a DVT or a cellulitis or a rupture of the gastrocnemius muscle, it can mimic all of those things. Okay, so that's basic important things you need to know. From a hematologic standpoint, what happens with RA? So you could get anemia, right? But the anemia, your iron panel would look like what? Right, so anemia of chronic disease is no longer called that, it's called anemia of inflammation, right? This is when your ferritin will be really high and your iron will actually be low, right? So you will actually have that happen in this patient as well. Could you also get pancytopenia with rheumatoid arthritis? Yes, why? When you have rheumatoid arthritis, are multiple joints and multiple areas of your body constantly getting damaged? It is, right? So whenever you get cells damaged, are you having constant turnover of cells? You are. So if you have a constant turnover of cells, you have to form more DNA. In order to form DNA, what do you require as a vitamin? Folic acid. You require folic acid to form purines and pyrimidines. So if you don't have folic acid, because you're going to run out, if you're going to be constantly in this state, you will run out of folic acid and you'll have a folate deficiency, which will lead to pancytopenia. So you can actually have a pancytopenia process that happened with RA. Okay, so I think this part is the easy part. The harder part is going to be treatment. So when you suspect somebody's got rheumatoid arthritis, how are we going to come to the diagnosis? Now, American College of Rheumatology has actually come up with a diagnostic criteria. It's 4 things you need to know about. Number 1 is the pattern of joint involvement. There's a whole scoring system that you can look, but if you have small joints, the classic small joints getting affected, then you get a higher point. Okay, so joints is 1. Number 2 is going to be presence of rheumatoid factor and CCP. So if you have low titers of rheumatoid factor and low titers of CCP, you get less points, but if it's high, you get a higher point. What else do you check for? ESR and CRP. If your ESR and CRP are elevated, you get a higher point. If it's low, you get a lower point. Number 4, important thing is duration. But typically rheumatoid arthritis needs to be present for more than 6 weeks. Reason is, sometimes you can have a viral infection that presents just like RA that lasts always less than 6 weeks. That's the important thing. Okay, so 6 weeks duration is important. So you need a total of 6 points in order for you to diagnose rheumatoid arthritis. So technically, do you need rheumatoid factor and CCP to be positive to diagnose RA? You actually don't. You can actually have seronegative RA. Absence of rheumatoid factor and CCP being positive doesn't rule out rheumatoid arthritis if everything else fits. Okay, so you go based on this criteria and you diagnose the patient. Once you diagnose, you got to start treatment. Before you start treatment in RA for any patients, what do you need to do? First off, what we need to do is get a baseline imaging of hands and feet, because those are the most common joints to be affected, because you want to see where you stand, what's the baseline, and you want to prevent them from going into an erosive disease. So you always want to get a baseline x-ray of your hands and feet. That's number 1, right? So you want to do that first. Once you do that, and now you want to start treatment on these patients, what is your mother drug when it comes to rheumatoid arthritis? Methotrexate. How are you going to give methotrexate?
15 to 20
Is it tablet or sub-Q? It's actually tablet. You want to start with tablets. And how much is the dosing? Typically you give about 15 milligrams for the week. It's not a daily dose. 15 milligrams for the week. And you can go up to a maximum of about 25 if you wanted to, right? But after 15, the absorption gets affected. Okay, so but 15, you want to start PO, and that's a weekly dose that you give. Okay, after 15, if you feel like they're not responding well and you want to go to a higher dose, they do consider you do a split dosing, break up the dose, or you can also go sub-Q at that point. But your mother drug when it comes to rheumatoid arthritis is methotrexate. Okay, what is an important side effect profile of methotrexate? Hepatotoxicity, good. So you want to get LFTs prior to starting methotrexate to make sure you know. It can cause pancytopenia. Why? Folic acid, because methotrexate blocks dihydrofolate reductase enzyme. So essentially what it's going to do is cause a folic acid deficiency. No folic acid, no DNA synthesis, pancytopenia, straight up. So how can you prevent that? Everybody with methotrexate, you must give them folic acid, which is vitamin B, what? Because they can trick you and say all the vitamin B's and you don't know which one is it. I know it's folic acid. It's B9. Okay, folic acid is B9. Okay, what else for side effect profile?
Megaloblastic.
Pretty much if you have folic acid deficiency, yes, you would get a megaloblastic anemia. Sure. What else?
stomatitis.
Good. You can get mucositis, stomatitis. Why does that happen? It's all related to folate. If you don't have folate, you cannot form new cells. If you cannot form new cells, then you're going to have inflammation and damage to all the mucosa. And remember, your mucosa and your gut, those are highly replicating cells. So they're always replicating. So they're going to need a lot of folic acid. What else?
Possibly interstitial fibrosis.
Yes, that's a very important one actually. So interstitial lung fibrosis can happen. So if somebody's got rheumatoid arthritis and on methotrexate, if they develop lung fibrosis, you want to question the existence of both. Could it be Kaplan syndrome or is it methotrexate toxicity, right? So think of methotrexate can cause this problem too. So say you're on methotrexate, but your patient is not improving. So again, if you start the patient on a drug, when they come back to your clinic and you want to see, okay, am I doing good? Do I need to do more, right? How do you assess the progress of your patient? Or is there a scoring system? There must be a scoring system. There's many scoring systems, but the ones they actually like is CDAI. CDAI and DAS28. It's a bunch of points of joint involvement. Some of them may have ESR, CRP. You kind of see that and use the score to kind of assess how you're doing. Okay, I don't think they're going to go into the scoring as much, but remember, you do use a scoring system to assess. Now you assess, and if you're not doing good enough, methotrexate alone doesn't seem like it is good enough. What's your next step? What would you add next? Sulfasalazine and hydroxychloroquine. You can actually add both of them and do something called a triple therapy. These are known as non-biologic DMARDs, including methotrexate. They're all DMARDs, right? Disease-modifying anti-rheumatoid drugs is what you want. So if methotrexate alone is not cutting it, next step, add sulfasalazine and hydroxychloroquine. Okay. Important side effects of hydroxychloroquine is what? Eye. If somebody's been on hydroxychloroquine for at least 5 years, after that you got to start doing eye exam because it's going to cause retinopathy. Okay. Another thing, hydroxychloroquine being a quinine drug can cause something called synchronism. It can cause ototoxicity. Okay. Something to think about, but the board is going to go after the eye because that's what you're going to screen them for once you start.
Post 5 years.
Huh? After 5 years. If you've used it for 5 years, then you got to start doing eye exams on those patients. So hydroxychloroquine. What about sulfasalazine side effect profile? Most of these drugs you want to know the side effect profile. You can have mucositis. Good. What else? You can get a skin rash. Okay, you can get a skin rash. You can also have hepatotoxicity, and it can actually cause a hemolytic anemia. Sulfasalazine is very notoriously known to cause a type of hemolytic anemia. So those are the 4 you want to remember for sulfasalazine. Okay. Now, if the question says patient is on methotrexate, or you don't want to give the patient methotrexate, but mild disease, do you have any other option instead of methotrexate to use? The drug is a leflunomide. You use a drug called leflunomide. What is an important thing you want to make sure the patient does not have before you start them on leflunomide? Yes, you want to make sure the patient is not pregnant or not planning on getting pregnant. It is very, very, very teratogenic.
Yes.
So if somebody is on leflunomide and now comes and says, hey, I'm planning on getting pregnant, right? What are you going to do?
Give them cholestyramine.
Good. You're going to stop the drug first off and you're going to give them cholestyramine for how many days? 11 days. 11 days cholestyramine washout. It will wash out your leflunomide, and after that, once they are off the drug for a while, then they can go. But that's what you want to remember. How to wash out leflunomide, cholestyramine for 11 days. Okay. Now, you could either be on methotrexate plus hydroxychloroquine plus sulfasalazine if the patient still worsens, or they say patient is coming but already has bad erosive disease. There's already lots of damages that's happened to the joint. At this point, do you prefer going with methotrexate, hydroxychloroquine, sulfasalazine combination, or do you want to bring in something new? You want to bring in something new. What's the new thing you want to bring in? Anti-TNF drugs. And this is your biologics, right? Anti-TNF drug is going to come in addition to your methotrexate. So you add to methotrexate plus anti-TNF. What are the 5 anti-TNF drugs you can use here? Etanercept, adalimumab, infliximab, golimumab. Last one, start with a C. Certolizumab. Very good. Okay, certolizumab. So when you're going to start somebody on anti-TNF, what do you have to screen them for before you start these drugs? TB. What else? HIV. What else? Hep B and Hep C. Those are the 4 you want to screen for. Once you screen, they get the clear, good. Then you'll start the drug. Can you ever use 2 anti-TNFs in combination? No, never. Never combine 2 anti-TNFs together. Just use one of them as an addition. What is the side effect profile of anti-TNF? What should you worry about? It can cause congestive heart failure. What else should we think about? Yes, you can actually have drug-induced lupus. Now, typically when you had drug-induced lupus, we always used to call them the HIP drugs. What are the drugs that's classically known to cause drug-induced lupus? Hydralazine, I4, isoniazid, P4, procainamide, and then also there's M, which is minocycline. Okay. But now you also have these anti-TNF drugs. They can actually also cause drug-induced lupus. Now all of them Previously, the understanding was they were only going to be positive for histones, not ANA, but now it's positive for both. ANA and antihistones, both are going to be positive. Typically, rash, arthralgia will be present. You will never ever have involvement of neuro or kidneys. That will never happen. Okay, so a very limited effect will be happening with your drug-induced lupus. Okay, so those are going to be your anti-TNF drugs. So if somebody's got erosive disease, you actually prefer to actually start them on anti-TNF with your methotrexate. Okay, now the next drugs, I don't think they will really go into it, but I think you might still need to know what those drugs are. So what other drugs can you use on the context of rheumatoid arthritis? Some of the drugs is CD20 blocker, which is rituximab, right? Rituximab can be used here. You also have a T cell modulator, which is called abatacept. Abatacept can be used. Then you also have JAK blockers, such as baricitinib, upadacitinib. Okay, baricitinib and upadacitinib. Okay, are the ones that's going to be used. What are some important side effects of your JAK blockers? It can cause MIs, it can cause cancers, okay? It can cause blood clots, and can cause strokes as well, right? So that's basically rheumatoid arthritis management. But from a management standpoint, knowing that your mother drug is methotrexate, and then you will add hydroxychloroquine sulfasalazine. If you don't want to use methotrexate, go to leflunomide directly, knowing what to do with pregnancy, and then if it was erosive, adding anti-TNF. That's the major part that you probably need to know when it comes to rheumatoid arthritis management. Now, that's all and well for disease modification, but if somebody is actually coming with an acute flare and you're actually having pain, then what can you use in those moments for the pain? Yes, you can use steroids, but you can also use NSAIDs, right? It's anti-inflammatory. You can use NSAIDs, but steroids, interestingly, has some disease modifying effect. You using steroids can actually have some disease modifying effect on the context of rheumatoid arthritis. Okay, so that's RA. All right, so let's move on to the next topic. Let's do scleroderma first. Okay, so when it comes to scleroderma, how many types of scleroderma do we have? Thank you for watching. If you like our content, please like this video, subscribe to our channel, and hit the bell icon so you get notified when a video is released every week. Have fun studying. We'll see you on the next one.